Welcome to Texas Briefing, where we untangle the policy challenges shaping life in the Lone Star State, one series at a time. This show is coming to you from Rice University's Baker Institute for Public Policy in Houston, Texas. This is the last episode in our three-part series on reproductive health. In the first episode, we talked about how new abortion legislation in Texas, where we have one of the strictest abortion bans in the country, is making its way through the legislature. Today, in our final episode of this series, we're looking at how these abortion laws are straining the state's OB-GYN workforce pipeline, with many OB-GYN physicians and residents making or considering changes to how or where they practice in response. I'm Elena M, a senior fellow in health policy at the Baker Institute and your host for this series. Thank you for tuning in. We already talked in our first episode about the strictness of Texas abortion laws, but as a refresher, the state currently bans all abortions except those necessary to save the life of the mother or to prevent substantial impairment of a major bodily function, which, as we discussed, means in practice that doctors and hospitals are frequently delaying or denying care in emergency situations because they're worried about the penalties they'll face. There are no exceptions for rape, incest, or lethal fetal anomaly, where the fetus is diagnosed with a condition that will result in death at or shortly after birth. So what impacts are these restrictions having on Texas's OB-GYN workforce and therefore access to reproductive health care in the state more broadly? We're going to go deep into the challenges for the workforce pipeline with Alex Morin, a managing director at the healthcare consulting firm Manatt Health. He's the co-author of a recent report from Manatt that presents the results of 14 interviews with physicians on how the ban is changing their practice experience. It's the follow-up to a study from October 2024 that surveyed all Texas-based members of ACOG, the American College of Obstetricians and Gynecologists, to evaluate how the abortion ban is impacting their work and the state's OB-GYN pipeline. So let's get to it. Alex, thanks for joining me.
Happy to be here.
So let's start with, what are the longer-term challenges driving poor reproductive health outcomes in Texas?
So I'm glad you're starting here. Our work over those two studies that you mentioned was laser focused on the OB-GYN physician workforce, and that was intentional. The sort of macro reason for doing so is directly linked to the outcomes that women are experiencing in Texas with respect to reproductive health. And the starting place in the state is rather bleak, shall we say. We leaned on an analysis that was prepared by the Commonwealth Fund, which characterized and ranked the 50 states, along with the District of Columbia, along several dimensions relating to reproductive health outcomes, access to services, care quality, different measures. And to sort of just give you the punchline, Texas ranks 50th overall, according to their composite score. Metric after metric reveals just a bleak picture for women in the state, and in particular, minority women. When we think about what constitutes a good outcome, a good quote outcome, there's a number of driving factors. Some factors relate to, for example, economic stability. We know that women in poor communities often experience more hardship during pregnancy, as an example. Similarly, factors relating to neighborhood, built environment, are women being exposed to lead or other harmful chemicals in their living environment, access to nutritious food. Other drivers are certainly important, but arguably the most important driver of a, quote, good outcome is access to reproductive healthcare services, from prenatal care through to pregnancy into postnatal care. And arguably the most important component of that is access to the workforce itself. So the bottom line, there's a number of challenges facing women in the state seeking reproductive healthcare services, including access to the workforce itself, and that is our starting place.
So the abortion bans are relatively new because they came about after Roe v. Wade was overturned. How is the OB-GYN workforce in Texas holding up before the abortion ban? And how did this compare to the country at large? The report you just mentioned, is that based on pre-ban data?
Yes, that is pre-ban data for the most part. That sort of showed the starting place, if you will, for health outcomes in the state for women. I would sort of summarize the physician workforce, the OB-GYN physician workforce starting place in two words: burnt out. My wonderful colleague and co-author on our first report, Dr. Daryl Kirch, is a former dean of medicine, also the former president of the Association of American Medical Colleges. And he's said to me and has been quoted publicly regarding burnout in medicine as, quote, burnout is medicine's opioid epidemic. He led a nearly 2-year study that was funded by the National Academy of Medicine on this topic and has sort of become one of our nation's spokespersons on this issue. This burnout issue certainly extends to the OB-GYN physician community, certainly extends into Texas. There's been a number of studies published that have looked at how this has played out across different specialties, within specialties, and so forth. So we know that this is an issue, and that is indeed the starting place. So you've got a burnt out workforce, and then you add to that a complicating factor, which is we don't have enough. We are facing a very severe shortage of OB-GYN physicians nationally, a very severe shortage in Texas. Just to give you a data point, by 2030, Texas is expected to have a shortage of about 15% of the full-time equivalent physicians that it would need to meet the demand that we're expected to see in the state. And almost certainly the impacts of that will be most acutely felt in rural communities as well as socioeconomically disadvantaged communities alike. So a burnt out workforce, stretched already in terms of demand.
Okay, so not a pretty picture. And then we have a near total abortion ban. Can you talk to us about what your research has shown that these bans are doing to the OB-GYN physician workforce pipeline?
I've been trying to find the right metaphor. I'm not a physician myself, but a metaphor to sort of describe this situation. I haven't found a good one yet, but I would just say sort of imagine yourself in your own career, struggling to keep your head above water, doing the best that you can to do the work that you have to do. You're deeply committed to your work and have been going above and beyond what is likely a sustainable pace for several years because the need for what you do is so great. And then you're told, by the way, we might throw you in jail if you do your work the way we don't want you to do it. That's kind of the situation that OB-GYN physicians and other physicians in Texas and these other states with abortion bans are finding themselves. Texas and other states have implemented new laws that create an incredibly complicated legal framework for how physicians, including OB-GYNs, deliver the care that they're trained to deliver for the women who need it. And there's no alternative. Abortion in these cases is the standard of care. So suffice it to say, the situation is now much more complicated for physicians who are delivering services to these women.
Your recent report talks about how the experience of practicing as an OB-GYN in Texas is changing as a result of the abortion ban, and it's based on a series of interviews with physicians. What are the themes that emerged from your interviews?
I think I can summarize the work of over our 2 reports into 5 themes. The first I alluded to already, which is that legal standards have replaced medical guidelines. We now have a situation where in evaluating whether or how to terminate a pregnancy, physicians are applying legal standards, clinical standards, and their own medical judgment, secondary at best. One immediate consequence of that is that decision-making, including in emergency situations where time is of the essence, is delayed because physicians are consulting with their leadership teams, they're consulting with general counsel's offices in cases that otherwise would have been managed very quickly and very compassionately. So we have the replacement of medical standards with legal standards. The second theme, which relates, the doctor-patient relationship has been significantly impaired. We talked to dozens and dozens of OB-GYN physicians. We talked to emergency medicine physicians. We talked to family medicine physicians who deliver OB services. And they reported to us pretty loud and clear that they feel no longer able to deliver evidence-based medicine. Patients are not getting the best care as a result, and the doctors that are delivering care have reported to us this sort of profound sense of moral stress, unable to live up to their oath, which is to do no harm, right? One data point just to offer, in our first study, 76% of OB-GYN physicians that we surveyed reported they felt unable to practice evidence-based medicine. That is a staggering statistic. So the doctor-patient relationship significantly impaired. Third theme, the erosion of clinical expertise. Put simply, what you cannot do, you cannot teach in medicine. So with the increasingly limited opportunity for trainees to manage medically necessary abortions, doctors are not learning how to do this. And I want to make one point here, which I think is very important, and I've talked a lot about as I've been discussing these studies with folks. What happens in Texas does not just stay in Texas. Texas trains a lot of medical students. They train a lot of residents who don't just deliver care in the state. They leave, they go elsewhere. I live in the District of Columbia. Undoubtedly, there are physicians who trained in Texas who are providing care in clinics and hospitals here. So what happens in Texas impacts the nation. And so the erosion of clinical expertise in Texas is affecting the nation. I think that's a very important point to make. Residency programs, for example, are now going to great lengths and taking great expense to send trainees out of state for a period of time in order to receive the training that they're required to receive from the ACGME. And it's becoming this kind of mad scramble for programs to find and maintain these relationships. And it's still not enough to ensure that everybody is getting the amount and the quality of training that they need. So we have this erosion of clinical expertise that's going to compound over time. Fourth, fear dominates the exam room. One quote that sticks with me from a physician that I interviewed was along the lines of, I do not know if I'm going to get in trouble because I did not give my patients options or because I did. And that sort of encapsulates this distress that is pervasive among the physician community. Fear and confusion are manifesting in different approaches that individual physicians or hospitals are taking as they interpret Texas law. Some doctors believe they're permitted to tell women that they can leave the state for an abortion. Others are afraid that if they do, they'll be prosecuted. Some hospitals only permit an abortion for an ectopic pregnancy if infection is present or if there's no fetal heartbeat. It's become this sort of chaotic environment in different situations for how physicians and their teams are navigating these laws. And lastly, the final theme that came out of our two studies, we've summarized it in a phrase that was often offered to us in describing this situation. It's just plain cruel. And this is specific to the lack of an exception for fatal fetal anomaly, which you mentioned in your opening. Women are being forced to bear all of the risk of a pregnancy and the grief over knowing that their child is not going to survive and carry that pregnancy to term. It is certainly emotionally traumatic. It's also physically very dangerous. And they've lost this agency, right, to make decisions for themselves and for their families. So those sort of summarize, I think, the two studies in their totality, and there's a lot underneath each of those that we can go into.
I want to come back to that last point in just a minute, but can you talk to us about what you learned about the pipeline? What's going on in med schools, residencies? Are OB-GYN physicians coming to Texas, leaving Texas? You described a situation before the abortion bans where we really didn't have an adequate supply or pipeline, particularly in rural areas. And you've just described the dire situation in which these physicians find themselves. How is that showing up in who's deciding to come to Texas, to go to med school, to go to residency, to practice in Texas?
So I get asked this question a lot, sort of, are we seeing decreases that we thought we might see in medical school applications and residency applications? And the short answer is no. Medical schools are still hitting their enrollment targets as best we can tell. Residency programs in Texas and in other states that have banned abortion are still filling, right, their approved slots. The long answer, though, is much more complicated. We have very clear evidence that medical students are, in fact, taking into account abortion laws as a factor of where they want to enroll, not just from a clinical practice standpoint, but do I want to live in that state standpoint, right? You have to go to live in a state for 4 years in order to complete medical school. And we have data from the AAMC that shows stark decreases in the overall number of applications to OB-GYN residency programs in Texas, in other states that have banned abortion. We don't have 2025 match data that I'm aware of yet, although that should be coming out soon. But for the 2022, 2023, and 2024 match cycles, we saw a 10.4%, 6.4%, and 16% decrease in total applications to OB-GYN residency programs in Texas year over year. In some ways, there's an undersupply issue happening of medical student slots and residency slots that masks the impact here. So programs are still filling, right, because we have more applicants than we have slots. And I think we might all agree that for an aspiring OB-GYN physician, a slot in a Texas program is better than no slot at all, right? So bottom line, we're not yet seeing medical schools not, fill out their enrollment targets or residency programs hitting their match fill rates. I think it's important, though, to note that the education and training pipeline life cycle, if you will, it takes about 8 years. So we're still very early on in being able to, I think, concretely say, has there been an impact on the pipeline such that we're going to see an impact in clinical practice? It's going to take a couple of cycles, I think, for us to truly see those manifest fully.
There's a bill making its way through the Texas legislature, and it looks like it's going to become law, called the Life of the Mother Act. And it was supposed to clarify when doctors can legally perform abortions in the situations you described, where a pregnancy is not viable and there is likely imminent harm to the woman. And a lot of the confusion that has surrounded that has caused doctors to have the experiences that you described. I know you're not a lawyer or a doctor, but do you have any thoughts on how the clarity in the act, which, as I understand it, essentially says you don't have to wait until the woman is about to die or lose a bodily function, is that going to give doctors and hospitals and the lawyers who ultimately make these calls for the doctors and hospitals the comfort that they need to be able to practice in their patient's best interest?
I'll start by saying I think it's hard to look at the base of information, the data that we've seen in the last couple of years since the Dobbs decision, and not still be afraid for the future, right, with respect to the workforce. As I said, we still, I think, need more time to fully understand the workforce impact itself. The Life of the Mother Act, I think it's hard to say. On the one hand, as you said, the law does provide additional clarity on exceptions on when a physician can legally provide an abortion. I did watch quite a bit of the hearings on this bill earlier in the year. And, there was certainly some support from the provider community. On the other hand, many, quote, on the ground, right, people have said the law doesn't do enough to both protect physicians and by extension, protect women, the life of the mother. It's not, really for me, I think, to say. I'll always defer to the experts on the ground. And I think my recommendation, I would simply say we need to keep the dialogue open. We need to understand, right, over the next couple of years, has the law alleviated some of the fear, alleviated some of the moral distress, right? These themes that came up in our work in the wake of the law, and revisit it. That's what I would say, the next 18 months to 2 years should look like.
So we'll be watching for that. I want to go back to your point about lethal fetal abnormalities. As I understand it, the Life of the Mother Act doesn't impact that at all. The bans are all completely still in place. All of the methods for penalizing physicians are still in place, criminal and civil. And the exclusion of exceptions for rape or incest or a fatal fetal abnormality are still in place. Is that correct?
Absolutely.
Even if the Life of the Mother Act clarifies and allows doctors to take care of their patients in ways that they have been afraid to prior to that, the impact of the bans are broader than just the situation described and addressed in the Life of the Mother Act. And do you have any thoughts on the totality of the circumstances and whether and to what extent the Life of the Mother Act fixes the problem that abortion bans created? How much of a fix is it?
So it certainly doesn't address all of the situations that were raised to us in our discussions with physicians about, in non-elective abortion cases, as an example, you need to provide the care, evidence-based care that they're trained to provide. The Life of the Mother Act does not address all of those cases, the primary example being the lack of an exception for a fatal fetal anomaly, which if a woman lived in a state where abortion was legal, they would have the option to terminate that pregnancy at the time where the fatal fetal anomaly was discovered. So it does not address the concerns overall from the physicians that we talk to, again, in the category of what I'll just call non-elective abortions, where there's a medical reason for doing so.
Anything that gives you hope about the situation for Texas patients and anything we should be looking for in the data over the next couple of years that can answer some of the questions that remain?
So there has been a number of studies since our report was published that have been trying to look more concretely at the workforce and flows in between states. And there's mixed results as of now. Are we seeing less physicians actually practicing in a state Are we seeing physicians move and register to practice medicine in another state? I think we're still early on in that more quantitative, objective journey. I think we need to continue to monitor that. So that's sort of what I would suggest folks continue to focus on, to make sure we understand, are we seeing the manifestation of a meaningful shift in the workforce that will further impact the situation for women in Texas and other states where abortion is banned. There are some things that give me hope. I spent dozens and dozens of hours speaking to physicians within the state over the last 2 years. Each and every person I talked to gave me their time, though many did not want to reveal their name publicly. It's just back to the fear theme. And the passion that they have for their work and the commitment they have to their communities is unbelievable. They simply want to do their jobs. So one theme that we highlighted in our first report was this sort of tension that exists within the OB community. On the one hand, most raised these grave concerns about the laws, the impact of the laws on their ability to care for women. Many in that group, we know, are thinking about potentially leaving the state, practicing elsewhere, or otherwise changing their practice in a way that would negatively impact access. But many I talked to are staying. And they're committed to fighting for their patients. They're committed to fighting for their communities. They spoke about, what would happen if they and their colleagues just packed up and moved overnight. Who would be left, right, to care for these patients in these communities? The sort of, if not me, then whom, was sort of the motto and was a common theme. So those people give me hope. I think short of a law change, only time will tell if that resilience wins the day in the state.
Thanks very much. It's an important and complex issue, and we really appreciate your research and expertise.
Thank you for having me.
Texas Briefing is brought to you by Rice University's Baker Institute for Public Policy, which provides meaningful, nonpartisan policy analysis on the most critical challenges facing the U.S., Texas, and the world. This episode was produced by Karina Zamel. AV production was led by Kevin Young. You can check out our other podcasts and keep up with our latest research and events at bakerinstitute.org. Thanks for joining us.